for having us. It's great to be here on such an important topic, and we are blessed to have a remarkable panel in both diversity of geography and expertise. And I'm going to start at my far right and ask Dr. Trestman to start off and introduce yourself, and go down the line here and everyone introduce yourself and tell everyone who you are and what you do, if you don't mind.
My pleasure. Good morning, everyone. I'm Bob Trestman, professor and chair of psychiatry at Virginia Tech Carilion School of Medicine and at Carilion Clinic. The work we do is spanning both the development of new initiatives through our research efforts and collaborations, as well as providing care to the 325,000 or so patients who are currently under Carilion's care in our 6-hospital chain and our 50 patient-centered medical homes that span about 250 miles up and down the eastern edge of the Appalachian chain.
Karen?
I'm Karen Velkey. I'm the Corporate Vice President for Compensation and Benefits with Huntington Ingalls Industries in Newport News, Virginia. So our group is responsible for all of the benefits plan design and administration for all of our healthcare benefits. So we have, of course, most of you probably know Newport News Shipbuilding in Newport News, Virginia. We also have a shipyard in Pascagoula, Mississippi, as well as the Technical Solutions Division, which is headquartered in Virginia Beach, but also has some operations in Northern Virginia and all over the United States.
Kia.
Good morning, everyone. My name is Kia Dunbar-Harris. I am a Director of Clinical Care Service and Operations at Optima Health. Optima Health is a managed care division of Sentara Healthcare here in Virginia. Our headquarters is in Virginia Beach. We cover about 450,000 lives in the Hampton Roads, Virginia, North Carolina area. We have multiple health plans, commercial, Medicaid, and Medicare plans.
Mark.
Good morning. My name is Mark Merrill. I'm the President and Chief Executive Officer of Valley Health System. We are headquartered in Winchester, Virginia. We serve the northwest corner of Virginia, West Virginia, and parts of Maryland. Our hospital system is a very rural community. We have the dubious distinction of being in close proximity to 5 jurisdictions as it pertains to drug management. We're a hop, skip, and a jump from multiple jurisdictions, and that shows up in our patient population. We are a very rural area. Valley Health is the largest employer, and each of our hospitals are the sole community providers in each of the communities that we serve. So we have a very huge safety net responsibility. So when any health issue comes up, we are the only health system to be able to respond to that.
So it's going to be wonderful to hear everyone's different perspective. We got Dr. Trestman, who actually works in addiction, is going to talk to us a little bit, I think, about the disease of addiction. Karen, with the largest private industrial employer in Virginia. Kia, from the health insurance standpoint. And then Mark, obviously, is a healthcare delivery, CEO of a healthcare delivery system. Mark, why don't we start with you, because you mentioned you're in a rural area, and Delegate Moorfield said that, of course, this issue has ravaged Southwest Virginia. In general, how has the crisis impacted your operations up in the Shenandoah Valley?
It's had a huge impact. I mean, our community went from having 1 to 2 deaths, 9, 10, 11, and 12, to a spike of over 20, 30, and we plateaued at 30, and we thought we were starting to stem the tide until last year. We had 40 deaths to opioid in our community. So there's a social and human cost of that. We have seen in our region almost a doubling in the social services budgets. And the largest driver of the doubling of social services, in particular for foster care, is because of parents who are unable to care for their children and the children being placed in foster care. Going from $1.5 million to our rural area to almost $3 million, driven pretty much by opioid and drug abuse. The incidence rates of neonatal abstinence babies has increased. Back in 9 and 10, about 1% of our babies born at Winchester Medical Center and Warren Memorial Hospital, where we have OB services, were some type of neonatal abstinence. Now it's up to 2%. The average length of stay of these babies is almost 30 days. Their cost is more than 10 times the cost of a normal newborn. And then the economic cost in terms of lost employment as well. So it's a huge economic cost to our community. And unfortunately, the only place that we had treatment back in 2012 and 2013 was the Northwest Regional Detention Center. They had the only 90-day program for drug abuse and drug treatment in our region.
Wow. Kia, how about your perspective as working with Optima and health insurance plan? Can you discuss the financial impact substance abuse has had the expenditures of your plan and what you've had to focus on or maybe change or maybe had to offer in terms of different offerings that the business community may have wanted and that sort of thing?
Sure. I'll actually talk about first our NICU cost and NICU admissions. Of course, babies born with neonatal abstinence syndrome or NAS cost exponentially more than a normal birth. And the cost associated with that is the complexity of the hospital stay and the length of stay that increases. The normal length of stay for a baby with a normal birth is about 2 days, 1 to 2 days. And a baby born with NAS and has to be admitted at a NICU level of care ends up staying anywhere between 16.1 days up to 30 days, which again increases that hospital cost. It also trickles down to the number of employees that we actually have on the back end of that, because Optima Health has an integrated health system and we have a very robust case management system. And these case managers actually follow not only these babies after they are eventually discharged from the hospital, but also follow up with the mom to coordinate with different types of services and things in the community. The other cost is the overutilization of the emergency department. On average, the cost for an emergency room visit is anywhere between $800 to $1,200. And we were seeing an increase in the utilization of individuals hopping from ED to ED in search of new prescriptions, and of course the number of individuals admitted to the ED as a result of an opioid overdose. So there was associated cost to there as well. And going back to the case management and the nursing cost, we've had to increase our workforce, which is not bad for the economy because we are applying, new jobs, but we did have to include that in our budgets moving forward, the estimated cost that it would take to be able to have adequate reach out and engagement with these members to get them to engage in different types of case management programs and substance abuse programs that we offer from a health plan perspective.
Karen, I think probably a lot of people are going to be interested in your perspective, given that you work for HII and you do have a rather large workforce. Maybe you could just globally explain to us what some of the associated costs have been for substance abuse and addiction, for the last 5 years or so, and how you all have had to handle it and where it's been on your list of priorities, whether it's gone up or down or, that sort of thing, and kind of give us a general idea of what a large employer has had to face given this crisis.
Right. Well, I think that it was something that we probably didn't think about as much as we should. And then it really hit our radar screen when it went from, we have a policy, which I'm sure most of you do. We kind of look at, what are our heavy hitters? What are our top 10 claims incidents? What are our top 10 costs? And this was never, it never hit the chart, right? Until one year it did. And it all of a sudden went from not making the chart to making our top 10. And it took us by surprise, to be perfectly honest. And so we really started to take a look at that. And I think the thing to really understand is, obviously we're a very large employer. We have a very large plan. So the dollars associated with those claims weren't ever really the issue. It didn't become our biggest spend, but it did become our biggest increase. When you see a triple-digit increase in mental health and substance abuse claims, it's time to start taking a look at what's going on. And so we became really interested in what's happening around that. And I think we'll probably talk later about some of the things that we did to address that. But what we still see is, even though our incidence of opioid prescribing and things like that has gone down, the cost associated with opioid-related incidents still continues to increase. We've gotten a handle on that a little bit, but so exactly like Kia said, you see more emergency room visits, and that tells us, there's a crisis. By the time somebody is in the emergency room because of an opiate-related incident or a substance abuse issue, they're in crisis. So the encouraging thing I think now is, even though our costs continue to increase, they're not spiking the way they used to be, and we're seeing more of those costs go to outpatient treatment, to inpatient treatment, and our hope is that people are receiving treatment at an earlier stage before they're in crisis. So, but when you think about other associated costs, and I think, the senator mentioned that earlier, there are so many long-term implications, especially with prolonged opioid use, that I think it's really hard to quantify, right? That we don't know when you see a person who maybe has long-term organ damage or long-term health impacts, you can't really pin that down, but we know that it's there. So there's certainly that. And then the other things that you don't always quantify either, lost time from work and productivity. And, the delegate talked about that there's, if it's your employee, you can certainly say, oh, that employee missed work because they have a substance abuse problem. But employees miss work even if their family members have substance abuse problems. Or they're helping to take care of that baby that's not theirs, who's a family member who has been born that's addicted. So all of those associated costs really hit us hard if we can't get a handle on those things.
Have you been able to quantify the absenteeism and productivity loss at all, or is that's pretty tough to do, isn't it?
It is. It's a little bit hard to do.
Yeah, particularly with a... Why don't we switch gears a little bit? Dr. Trestman, you're in a unique position, not only as chair of psychology at Psychiatry at Carilion, but also working with a workforce of 14,000 people. So you see both the treatment angle and then your colleagues in the workforce angle. Maybe for those in the audience who don't understand addiction as much as some others, why is it so difficult to treat?
I think that's ultimately, maybe I should stand on one leg and balance one.
Yeah.
It's such a huge, complex issue. And it's multi-layered. I think part of it is our cultural stigma associated with addiction. Part of it is our unwillingness to recognize it. Additionally, we have historically seen addiction as a moral failing. And that undergirds a great deal of our entire social perspective. We don't tend to see it as an illness. And because of that, our whole mindset has focused on criminal justice as the appropriate intervention. Our challenge is to understand, as was wonderfully reflected in the earlier conversations by our delegate, commissioner, and senator, in the fact that it's a brain disease. It is based in changing the way the body deals with it. Our bodies were designed to survive in the wilderness. We are not yet adapted biologically to society. Society hasn't existed that long compared to the human body. The same circuitry in the brain that drives us to breathe, to eat, and to reproduce are the same circuits that are triggered by addictions, whether alcohol, methamphetamine, or the opioids. And because of that, our body reward mechanisms are readily overwhelmed by these incredibly potent drugs. And initially, it is a reward to take drugs. But over time, we experience it as, oh my God, if I don't get the drug, I'm going to suffer excruciating pain. And as we grapple with that individually, it's extraordinarily complex. How do you deal with it with your coworkers? How do you deal with it with your family? Who can you talk to? How do you get support? How do you get treatment? And so, because of all of those factors, it's made it extraordinarily difficult for us to be able to treat in a logical, coherent fashion. As we recognize that it is a genuine brain disorder that is built in to our bodies, we have to recognize that it is a propensity, and it is some of us are at far greater risk than others, in the same way that some of us are at far greater risk of becoming hypertensive or diabetic. Some of us are at greater risk of having cancer, others at greater risk of having bipolar disorder. It's who we are. And if we can acknowledge that, we can then address it rationally, apportion resources and supports appropriately.
What do you see in the trenches as the cost of inadequate substance abuse treatment?
We are ripping apart the fabric of our society. I mean, that sounds melodramatic, but it's actually quite accurate. There are communities in Virginia as well as across the country whose structure, you will find more ruptured families than you will intact families. You will find virtually no one who doesn't know someone who is addicted or has died from it, whose futures are cut short. One of the research findings that we are dealing with and turning into treatment predictors and management is something that Dr. Warren Bickel had championed. He's one of the senior researchers at the Virginia Tech Carilion Research Institute. Simply that when most of us think about the future, we plan 3 years, 4 years out. We prepare for our kids' college funds, we do all sorts of things. But on average, when we talk about the future, it's 4 years from now. Someone with an opioid addiction, their future horizon is 9 days. If they're currently in withdrawal, their future is 4 hours. They don't think about it beyond that. They don't plan. So in the context of destroying relationships, if it's not going to be something of relevance for more than 9 days from now, why should I bother thinking about it? So the social impacts are profound. The impact on healthcare professionals, the pain that we experience when we lose a patient to an opioid-related issue, the consequences throughout the fabric in our communities and individually, it's hard to overestimate, with potentially a couple of exceptions. One of which, certainly in the western part of Virginia, we're all too keenly aware of, is alcohol. And in our conversations here, it's important not to forget that while we grapple with opioids, we should use this as an opportunity to think about how we can also address the complications and the challenges of the social lubricant of alcohol that also compromises and kills far many more people than even do the opioids. The other is just the contextual framework of AIDS and HIV, which in the 80s and 90s was front and center. It's transitioned to the management of a chronic condition, to prevention, harm reduction, and adequate treatment. We can do that, and we can reframe opioid addiction in exactly the same way.
Kia, turning back to you, has Optima introduced any initiatives or programs to deal with this issue?
Well, I'm going to speak about one of our safety initiative programs that was actually started about 6 years ago. It was a program to identify high-risk members with overutilization of controlled substances. So we received data of our members who have 3 ED visits within a 6-month period, a combination of opioids and benzodiazepines, multiple prescriptions for controlled substances, doctor and pharmacy shopping, which is 3 or more prescriptions written by 3 different doctors and 3 or more pharmacies. So that initiative started 6 years ago, where we would identify those members and enroll them into our safety initiative program, which is a combination of our pharmacy team and our case management team, managing these individuals very closely with telephonic phone calls and getting them to actually agree to lock into one provider who would be responsible for providing all of their prescriptions. So that with that program, we've seen some initiatives, and then in April 1st of 2017, we actually initiated the ARTS program, which is the Abuse and Recovery Treatment Services with Optima for our Medicaid population. And what that did was take the safety initiative program that we already had in place and kind of took it up a notch with the engagement and the services and benefits that we now provide for our Optima member. The increase in the benefits include coverage for residential treatment, short-term residential treatment for substance abuse. It provides benefits for peer services or peer support. It provides services for acute inpatient detox. And these are all in conjunction with our safety initiative program that was already in place. Some of the other things that we've done is some of the rates for reimbursement have actually been increased for those services. And really big on the peer support and trying to engage our members in getting the help that they need. We actually enroll any members who have been identified with a substance abuse disorder. We enroll them 100% of those members into our case management programs. One of the other things that we did, we partnered with another vendor. I'm going to go back to talk about some of our NICU cost again. In 2015 to 2016, we spent about $25 million on 615 NICU babies, which about 18 to 20% of those were NAS babies. So we actually partnered with a vendor to provide case management services specific to that particular population. And this case management vendor, they follow the babies while they are still inpatient and then follow them all the way up until 1 year of birth. And what is unique about this service is that they actually follow the baby and the mom, and it is extensive high touch with these moms to get them the services that they need out in the community. The frequency that they are in touch with the moms depend on what type of services that they need, and they continue to provide them with education. They help them with trying to identify any barriers to treatment or adherence to their treatment plan. So they assist with any type of transportation issues. They assist with follow-up, helping them to establish and maintain their visits with their providers. So those are two of the main things that we are doing right now to assist. We're also looking at some benefit design changes as well to help with pain management and working with our providers with that as well.
So it sounds like you're really looking at your data as well. And Senator Donovan talked about the government's data and how they're trying to corral that, I think. But you in the private sector drilling down in your data and then proactively sending out letters to patients or providers or prescribers and saying, hey, we're seeing a trend here.
Yes.
Great. Karen, how about you? What plan changes or initiatives has HII put in place to deal with this in the last 5 years or so?
So one of the things that, from the earlier panel, they were a great setup for us, by the way, so nice job with that. One of the things they mentioned was really working with, the benefit providers that we have. We are the buyer, right? And so they're very good to work with us and help us to set up programs that really address these issues. So one of the very first things that we did was we worked with our PBM, our Pharmacy Benefits Manager, and ours happens to be CVS. So we were an early adopter of a policy that they later rolled out with. So we started it in July of 2017. They rolled it out to everybody in 2018, I believe, of MME procedures. And you asked me earlier if when I got this job I ever thought I would implement anything about MMEs. I didn't know what MMEs were.
You're talking about morphine milligram equivalents.
Morphine milligram equivalents, that's right.
Which has become the kind of the standard for prescribing opioids in Virginia with the Board of Medicine and whatnot. But in any event,
that's
you're right.
And basically getting a lower dose of an opioid to a patient, the lowest dose possible to help with pain and not overprescribe. That's the goal of it. And so we started that early with CVS, and since we've done that, through the time that we did that to the first quarter of 2018, we've seen a 39% reduction in our opioid prescriptions and a 21% reduction in utilizers of opioids.
Simply by working with your PBM. Wow.
Well, so yes.
Yeah.
And in addition to that, so you never can quite tell unless you just change one thing at a time,
Sure.
which is a slow curve. So the other thing that we have, and we've talked to this group before, is we have our family health centers at both of our locations, both in Virginia and Mississippi. And they are also very engaged in trying to reduce the ever prescribing opioids in the first place if there are other methods of pain management. So they nationwide, so they're Quad Med, nationwide across their entire book of business, they were on a mission to reduce their prescribing of opioids by 25%, and they exceeded that goal over the past year and a half, and have reduced their prescribing of opioids by 34%. But I think the thing to point out about that, and you and I talked about this, is one of the things we wanted to make really sure of, and they mentioned that earlier, is that we have good foundations for our other portions of our plan in place, so that if we take those things away, and we say, you can only prescribe less opioids, you have to have lower doses, less prescriptions, that you have other good options in place or good alternatives for people who do have pain, and that you have some common sense around that, right? So, you and I talked earlier, a lot of those rules don't apply to people who have chronic pain from cancer and things like that don't make sense for some of these rules. So we did make sure that those things are in place, that we do cover alternate treatments, that we do have first step therapies in place for those patients. So, but it has been effective, and like I said earlier, we do see our instance of opioid prescribing going down, and our instance of other methods, outpatient treatments and things like that, going up. So.
Mark, turning back to the Valley, would you mind talking to us a little bit about the Northern Shenandoah Valley Substance Abuse Coalition and what your involvement with that and the overall approach up in your neck of the woods?
Sure. This is an initiative we are quite proud of.
Yeah.
I mentioned the spike in opioid-related deaths between 11 and 12 to 13, and that was a wake-up call for our community. And as Dr. Trestman said, we came to the conclusion that we need a new community definition of what is drug abuse. And we can no longer treat it as a behavioral issue. It really has to be considered as a disease that is a chronic disease and has to be accepted by the community as a chronic disease. So we were fortunate that we also had a very enlightened chief of police who came forward and said we cannot arrest our way out of the problem, that we just can't keep building jails. So we came together, and I was confronted with, what's Valley Health going to do about this? And I said, well, it's not what Valley Health is going to do about this. What are we going to do about this? So the Northern Shenandoah Valley Substance Abuse Coalition emanated from the public defender, the juvenile court judge, the chief of police, the Frederick County administrator, the city administrator of Winchester, Valley Health, and the public health, the district public health official, Lord Fairfax, to come together as a coalition to start dealing with this particular problem. So the results of the past 5 years have been phenomenal. We first created a not-for-profit organization. The 3 jurisdictions, Winchester, Frederick County, Clark County, and Valley Health, contributed about $75,000 each to hire the first executive director. That executive director then worked to secure a grant to establish a drug court. So we've had a successful drug court program. Our medical staff leadership, I mentioned that we are the sole hospital system in our area, so we have a great ability to get all the medical staff practitioners together at once. So we started having comprehensive training and education of our medical staff about the risk of opioid prescriptions and the higher prevalence of people who got a 30-day subscription, how more likely they would be still on narcotics 1 year and 3 years later. So reducing both the dosage and reducing the duration of the prescriptions. We then started working with businesses about better education programs. The screening, Senator Donovan talked about the workforce. That's a big issue still for people who have a record. Trying to get them reintegrated into the workforce is a challenge, but we've done that with some local employers. We are participating with Dr. Melton mentioned the 5 sites about the SBIRT program, the screening, brief intervention, and recovery program. We now have peer coaches on call in our emergency department, so when a patient shows up who has an abuse disorder or has an opioid overdose or an alcohol overdose, we are putting them in touch with a peer counselor. And so, well, it makes sense. We have breast cancer support groups. We have Mended Heart for our heart patients. We have cancer survivor groups. Why not have support groups for patients who are dealing with the opioid or drug abuse problem? We also started looking at data. And we found as we started screening these patients for either a substance abuse or a mental health disorder, their frequency of hospitalizations for every condition, heart failure, COPD, diabetes, hypertension, those admissions were 2 to 3 times higher than for patients who did not have those comorbid conditions. So we have been working with our medical staff to start having more conversations with their patients about, do you have a substance abuse disorder? Do you have a mental health disorder? So we continue to work to advance our efforts. Most recently, with the Community Health Services Board, the state has stepped up and has really invested more resources and programs into our community for aftercare treatment. So that it's not, the only option is not jail, to have a program. So it's been wildly successful. Obviously, it's going to be a journey. It's going to be like treating diabetes. We're not going to eliminate substance abuse, but bringing more attention to it. And then last but not least, we try to find a number of things for surgical patients and for OB patients. So our OB department are screening all their prospective moms. They're not refusing to treat them. They're saying, okay, if you are an abusing mom or you have a substance abuse disorder, what can we do to make sure that you have the greatest likelihood of having a healthy baby? And we have had some great success with reducing the number of women, increasing the number of women who are enrolling in programs during their pregnancy.
Well, congratulations.
Oh, thank you.
Dr. Trestman, would you mind kind of giving us an overview of kind of where the prescribing for opioids stands now at the Board of Medicine briefly, just for the business community who may not know that there are new regulations, just briefly, and then maybe what some of the current treatment is for addiction versus a lot of people think it's still inpatient, aren't aware of buprenorphine and outpatient, that sort of thing, and kind of just educate the group a little bit on that if you don't mind.
Sure. The board and the legislature in Virginia has been very forward-thinking, has really initiated some structure to give guidance to all prescribers, which is reflected in the prescriber database that we each look into to be sure of what people are already being prescribed. There are limits around acute prescribing for 14 days after a surgical intervention, after a traumatic event. What are the limits in terms of the MME of equivalence, whether it is any kind of an opioid, how much of it is prescribed and for how long. If anyone is on a chronic maintenance of opioids, there is an obligation to check on a regular basis to be sure that they are below typically 120 MME, which is still pretty high. Most people who are naive to opioids, if you had that much, you'd be asleep pretty quickly and potentially not breathing for very long. So what we try to do with those laws, that gives us structure and guidance. It also makes it easier for our clinicians to set limits because it's the law. I can't give you more. That helps. The other initiatives are interwoven into that. And I just want to very briefly mention a lot of the things we need to be aware of. It's not just physicians, it's also dentists. Tooth extractions. They hurt. And so what are the alternatives? What are the limits? 2 days, 3 pills maybe of an opioid may be all that's necessary, if that. It's important for us to think about alternatives at the front end. What other alternatives? The non-steroidals like ibuprofen can be extremely beneficial. Or something called paracetamol, which is a combination, many are nodding their heads, of just ibuprofen and acetaminophen. So when we do this, we come up with ways of protecting our patients at the front end. When we are working with this, we also need to think about how to support our prescribers so that when they see people, how can they appropriately have a conversation and to reduce the amount of prescriptions they're on and to address the underlying conditions. There are clearly exceptions. When someone is in hospice, when someone is dealing with chronic extreme pain associated with a cancer, that's a completely separate issue, and it's important to acknowledge that. But for so many of us who have chronic back conditions or consequences of a car accident, we need to be very thoughtful about the use of physical therapy to work to overcome it. We need to acknowledge the fact that pain can be part of the human experience. We cannot expect that we all can live pain-free. Anyone over the age of 30 would likely experience and acknowledge that. And so coping with that is a part of who we are, and that's a part of the conversation. It's the issue of how do we help people to be functional, not to be pain-free. In terms of treatment, there are many, many alternatives that we need to be able to make much more readily available. Evidence-based alternatives exist, whether they may be different forms of acupuncture, of mindfulness, different kinds of meditation, physical therapy. There are many, many different alternatives, as well as other pharmaceutical interventions. Now, pharmaceutical interventions can be simply as alternatives, whether that may be socially radical alternatives that might be appropriate, potentially different formulations that are derived from marijuana. And keep in mind that it gets more and more complex as we look at it. It's not simply a marijuana brownie that we would be feeding to people. Hopefully not in this state. Okay, so the others are, historically, just as with alcohol, the treatment was bread and butter abstinence treatment. Alcoholics Anonymous, Narcotics Anonymous, which can work phenomenally well for many people, but not for everyone. Abstinence requires a great deal. It requires a lot of social support. It requires typically stability, ideally having a job as a big piece of it and a safe place to live. While those are also needed when we are doing treatments with medication assistance, the medication assistance can go a long way. We know that methadone works. For many people, there is, again, a cultural or social expectation that all we're doing is giving people who are addicted another addiction. They're being addicted to methadone rather than to heroin. But that's a lot like saying to someone who's a diabetic, now you're just addicted to insulin? I mean, if there is a brain-based disorder, a biological disorder that we can treat, and we can keep people both alive as well as productive members of society, then we need to consciously examine our own beliefs. Methadone was the traditional medication used orally on a daily basis in methadone clinics, highly controlled, highly stigmatized. Over these last 2 decades, we've come up with alternatives. One of them is buprenorphine, which is typically administered in combination with a blocker that can prevent the high. So it's typically sold as Suboxone, is one of the preparations. And the benefit to that is, in combination with skills-based kinds of psychotherapies, we can help people to stay off of illegal substances, to lead meaningful lives, to re-engage their families, and to overcome addictions. It is phenomenally rewarding as a clinician to see someone transform over 6 months, 12 months, 18 months into a productive citizen from someone who had been rock bottom, going into the ED, being recovered with Narcan after an overdose. So these are the opportunities. The one other thing I just want to mention is medication-assisted therapy is critical. It absolutely is. But the state has developed and is utilizing a wonderful approach, outpatient-based opioid treatment, which is a step above traditional medication-assisted therapy because it formally integrates in an outpatient setting the use of a medication like Suboxone or a buprenorphine preparation with psychotherapy that is typically and ideally an evidence-based psychotherapy designed to give people the coping skills they need to rebuild their lives. You know, it's like the old joke, don't think about a pink elephant. I mean, our brains don't work that way. We think about a pink elephant. We can't tell someone, don't do drugs. That doesn't work. We have to give them alternatives that are functional. other coping skills. We have to help them rebuild their lives in a meaningful way. And so as we do that in combination with the medication, we can really transform this epidemic.
Why don't we transition a little bit to the future as our time is wrapping up here. Kia, what are any future initiatives that Optima may have as we look forward?
Well, we're definitely going to continue our work with the arts program. Just coming up on the year of the implementation of arts, VCU had released some really promising data. They showed that in 2016, the total ED visits attributed to substance use disorder was 13,592. However, after the implementation of the arts program and in 2017, those ED visits decreased to 9,374, which was a 31% decrease. So we're definitely looking to continue our arts services, our case management services in connection with the arts program. We've increased our staffing to be able to better service our Optima members. We've included not only nurses with behavioral health backgrounds, but also looking to hire licensed clinical social workers to come aboard our team as well to address some of these ongoing issues. The first panel talked a little bit about parity. We definitely have aligned all of our medical benefits with our behavioral health and substance use benefits. And we have, for years now, Optima has integrated those things where we are no longer working in silos between a behavioral health team and a medical team. We've actually combined those teams to create a holistic approach on how we actually manage our Optima members. So therefore, a member who has other chronic medical conditions will also have their substance abuse or mental health issues all managed by the same team who have the particular skill set to manage those type of members. Also, we are looking to move the arts program into our mom and baby program because we know that, as stated before, the NICU population is an area where we've seen an increase in those NAS babies. So we are looking to better service our pregnant moms when we are identified that they're pregnant and getting them the services that they need earlier and trying to reach them earlier, and then to continue outreach and services to them after they deliver to help to promote wellness for the mom and the baby.
All right. And Karen, I'm going to ask you to maybe give a final few thoughts on some ideas businesses could have to have going forward, and wrap up with Mark, and then our time is about up.
Okay, well, I think the one thing we want to make really sure about is that there's access, that we do everything we can to provide access to mental health services overall. And so we've really tried, let me say this, and especially to reduce any barriers to access and that stigma of getting care. That really, I can't stress how important that is, and we do everything we can to help that, but it's still there. That stigma is still there. So some of the things that we've tried to do, we've implemented a telephonic behavioral health system where people can call. If some of you have heard of Teledoc, or I forget what the other one calls, Doc Live MD, I forget what it's called.
MD Live.
MD Live, thank you. And so you can use the same thing now to call on the phone. Sometimes people are still just they're still reluctant to go in person and talk to somebody when they have a problem. So we've implemented that. It's taken off, but it's a little slow. And then we've increased access to our EAP providers. We want to make it really, really easy for people to go and see EAP providers. So we've put more on-site EAP providers, but still, that's hard. I think people are still reluctant to go to EAP. EAP has a stigma, that name EAP. For years and years, if you didn't go to EAP, you got sent to EAP, right? You know this, if you're in a manufacturing environment, you got sent to EAP when you caused an accident, right? And if you caused an accident, what did you have to do? You had to take a drug test. So, we really want to encourage people to go to EAP. So we're going to talk more and more. This is one of our initiatives for this year. We're going to talk about mental health, and we're going to talk about substance abuse. We've just, we had something in our newsletter this week. We're going to send a postcard to your house. We're going to put posters in your workplace that say, here's what you can do if you think a friend has a substance abuse problem, not you, because I'm asking for a friend, right? If you have a friend that has a substance abuse problem, and we're going to talk about it more and more and more, so it's just as common as talking about if you have diabetes. What do you do if you have high blood pressure? What do you do if you have diabetes? What do you do if you have a substance abuse problem? And we're going to try and just keep taking that stigma away.
All right. And Mark, could you wrap up for us? Maybe we didn't touch on the data sharing piece, but and what people could do maybe in their part of the state if they wanted to try to create one of these coalitions.
Yeah, sure. Certainly, we're more than willing to help any organization that would like to pursue this. I'd like to echo the comments that Senator Donovan made about information sharing. We were fortunate to be able to get our region designated as a HIDA, a high-intensity drug trafficking area. And for those of you who are unfamiliar with the northern Shenandoah Valley, 81 to 70 is called the heroin highway. And there are people in our community who will go to Baltimore 3 to 4 times a day for drug deals, because it really is an hour and a half away. And Baltimore is a huge source of the substance abuse that comes in here. So working with law enforcement, both federal, state, the FBI, ATF, we were able to get our area designated as a high-intensity drug trafficking area, which allows great more information sharing. And I think the efforts that Senator Donovan talked about with regard to have other jurisdictions share that information and not having to wait for the HIDA. The other area that we're penetrating right now is high schools. We're trying to get information out to middle schools and high schools about the problems of substance abuse and try to get a little bit ahead of the curve until they're abusers. So that's been a huge effort of ours to work with the public schools districts in our region.
Panel members, thank you for your expertise and spending your time with us today. Really appreciate it. Thank you so much.
Thank you.